Good evening. My name is Christine Macy. I'm a professor in the School of Architecture at Dalhousie University and your host for this evening's discussion. Welcome to everyone, all of our viewers. We're so happy you could join us this evening for a discussion of the design of our healthcare system. The COVID-19 pandemic heightened awareness around the structure of healthcare systems. This includes the design of the physical and virtual environments where healthcare is delivered. Many of the issues are not new. The importance of supporting frontline workers, for example, or controlling the spread of infection in healthcare settings. But now a social dialogue is starting to take shape on how aspects of our healthcare delivery system are prioritized and designed, from long-term care facilities to academic medical centers. Designing for the future is critical. Joining us for the discussion this evening are two healthcare designers who will share with us their current thinking about this future and the impact it might have on healthcare delivery in Canada and the United States. Please welcome Bryan Langlands, a graduate of the architecture program here at Dal and Tons, the principal and senior medical planner with NBBJ in New York City. His clients include NYU Langone Health, New York Health and Hospitals, Massachusetts General Hospital, Penn Med, Jefferson Health, and Atrium Health. Bryan is on the steering committee for the 2022 edition of Facility Guidelines Institute's Healthcare Guidelines, which sets the minimum requirements for healthcare spaces. He also chairs the FGI's Beyond Fundamental Library. He was a member of the Greater New York Hospital Association's COVID Surge Capacity Task Force, and he's spoken on the impact of the pandemic on future healthcare planning and design. Bryan is a fellow of the American Institute of Architects and the American College of Healthcare Architects. Benji Nickham is our second guest, also a graduate of our architecture program. He's an architect and lead of Nickham & Associates, an architecture planning and project management firm based in Halifax that provides services on projects impacting the lives of people who are navigating the complete continuum of care in Canada and beyond. Benji is an adjunct professor and a chair of the professional practice teaching group at Dal's School of Architecture. And he's also a content and instructional services provider at the Royal Architectural Institute of Canada. Benji presently holds directorships at the Design and Construction Institute, Halifax Stanfield International Airport, and the Canadian Museum for Human Rights. To begin our discussion this evening, I'm going to ask a few questions of each of our panelists, and then we'll open it up for the viewers to ask questions. So please, if you have questions for the panelists, post them in the comments section. So let's begin. Welcome, Bryan, Benji, and all of our listeners. We're going to start with two slides that Bryan has assembled just to give you a sense of the first topic that we're going to be talking about in this session, which is a brief comparison of the healthcare systems in Canada and the US. So this slide, we can sort of say, well, our two countries share a great deal in terms of history, culture, and demographics. We see some significant differences in how each country approaches healthcare. For example, this slide shows a comparison of the hospitals and also the number of beds. So we see that Canada has more hospitals for the number of beds, but the number of beds are very proportionate to actually the population differential between the two countries. In Canada, how healthcare is delivered, however, and how people are insured varies quite a bit. So in Canada, government-provided Medicare is the primary form of insurance, and private plans pretty much just fill in the gaps in coverage. In the US, on the other hand, government insurance covers the gaps left by the private market. Private insurance is the norm. And programs like Medicare and Medicaid provide a little bit of a safety net for people who aren't covered by their employers. So we could say in short that these two approaches to healthcare in two countries that are otherwise very similar are actually mere opposites of one another. Next slide. We could also look at some of the differences in population and health insurance. So the difference between the two countries is most evident in the approach to health insurance. You can see in the US, there's a whole array of different strategies taken to ensuring that population has some kind of coverage to pay for very expensive the very expensive costs of medical care. Whereas in Canada, everyone is insured at some kind of baseline by government and then have to purchase additional coverage for more extensive treatment. So our question to our two panelists, based on this initial 2 slides, is what are some of the shared challenges that we see between the 2 systems in the US and Canada? For example, in terms of providing leading-edge healthcare, in terms of issues around the financial solvency of the systems, the healthcare delivery systems, and also how decisions are made within these 2 systems about what's prioritized, the design of spaces and the like. So
Sure.
why don't we start with Benji?
All right.
Yeah.
Well, I think one thing that is very consistent in Canada is that we design our facilities, our spaces, to provide care with an eye to the kind of upper limit that we can push any resource, whether it's a financial resource, a human resource, or a spatial resource. We might project for a new facility what things will be like in 10 years and design to that. But pretty much we're at the top limit all of the time of what we can possibly achieve in the system. And I think this sets up for us what we saw in COVID is that this really is a bit of a precarious situation when we enter into something like a sustained crisis that goes on and on and on. Our facilities, our spaces, and our people are at just pushed to the limit. So that's one aspect of it.
I think, if we set aside the differences in politics and insurance and things like that, I think a shared challenge between the 2 countries and the healthcare systems is trying to figure out how to deliver the right care at the right time in the appropriate setting and environment to all people. And I think I may be wrong. I think Canada might be closer to that than the US. It's no secret here that quite a number of the lower income and underinsured people in the country, their first encounter with healthcare is actually to present themselves at the emergency department, primarily because, number one, there's a governmental regulation in place that they cannot be refuse treatment. They have to be treated. But number two, there's no copay. Imagine going to the emergency department just because you don't have enough money to pay a copay to go and see a doctor. So I think probably getting to, appropriate right people, right place, right time, right setting is probably shared between the two. I do think for the US, there's also inequities between states as to how healthcare is delivered. We don't have a strong national federal voice as to how to distribute that money and how to get adequate coverage to all. So I think that is something that we personally or need to work on nationally in the States to really get coverage. I think we saw, almost the population of Canada is the same as what's uninsured in America, which is crazy numbers. So.
Wow.
Well, that gives us a great intro, I think, just as a starting point into the focus of our discussion today, which is going to be really what we learned from the COVID pandemic. So with that, we'll move into 3 more slides and just paint a little picture. And again, thank you, Bryan, for preparing these slides. And then we'll move into the meat of our discussion around what we learned from COVID. So we're going to start with this slide, which looks at what happened with the population in terms of COVID, so that we can see a comparison between the population. Canada has about 1/10 of the population of the US, but it had a much smaller percentage of cases. Only 3% of the population had cases of COVID in Canada, whereas 10% of the population in the US. And there's a lot of reasons for that, and it'd be interesting to reflect on that. And then you look at the number of deaths from COVID, which were pretty much the same in terms of percentage of people who had COVID, which means that the quality of the care is relatively similar. But it does raise questions here in terms of how COVID spread within the communities. It may be related to the differences in having a coordinated federal policy, as Bryan referred to, and some of the challenges around population compliance with directives about how to fight a pandemic. Next slide. In terms of vaccinations, we can see quite a difference. Canada has now more recently tracked pretty well on delivering first dose of vaccines, although the vaccines were fairly late in coming. The US had a slow start, but with change in administration, quickly ramped up a very aggressive approach to delivering vaccinations. And we really see that in the result of the second dose of fully vaccinated people, and how quick that was. But of course, we know there's really issues around how easy it was to access these vaccines. And this is a challenge in both countries. In the US relative to socioeconomic status, and also the political ideologies of red and blue states, and in Canada, issues around, is age the best way to go? How much agency do the provinces have in making decisions around vaccine delivery and following national federal guidelines? Next. And this third slide, this is the last slide we're going to show today, is a really interesting presentation that Bryan, raised, which is this issue of the pyramid of care, caregivers' needs. And this is a little bit like Maslow's hierarchy of needs. At the bottom, we see the sort of primary, which is basically protect the health of the caregiver and provide sort of the baseline, what hospitals absolutely have to do, what medical care has to do. You're looking for safety and you're looking for clinical accuracy. And that's the kind of primary base, the bottom of the pyramid. The next set, the green set, is all about processes and policies. It's how care is actually delivered. And so it has to do with operations and communications and those kinds of issues. And at the top is really comfort and ease of use. And this is a lot about how caregiving is experienced, especially for people who, how they actually experience hospitalization. And that's often the realm we think of a design being most visible and less sort of embedded in the core operations of the hospital. So with that, and then a point here is that during COVID, a lot of this higher part of the pyramid sort of got stripped down, and we saw hospitals and care centers being absolutely focused on just bottom line. Are there enough beds? Do we have enough oxygen? Can we manage this with the ER? And all those other issues of comfort and safety and operations. It's just like we've got to get people living through this pandemic. And so one of the things we might talk about in this next section is what we learned from being stripped down to these essentials that Benji referred to right at the beginning. And if Canada doesn't have a lot of capacity and resiliency to deal with challenges like this, especially ones that are sustained for over a year, how might we plan better for a future pandemic? Might we consider a different way of perhaps structuring this pyramid to provide more resiliency and more robustness in the face of similar challenges? So with that, I'd like to come back to our two speakers and just start a few questions. So Bryan, I was hoping you could talk about what you experienced with your clients in the US in places like hospitals or also in campuses and impacts on general operations.
Sure. I think we'll probably get into infrastructure later, so I'm going to speak a little bit more about operations and business. I think, my bulk of clients are large academic medical centers. They're a little bit of a different animal to, your community hospital and things like that. But what happened was that there was a complete shutting down of business as we know it. It happened immediately, especially in New York City. It happened fast, and we were inventing things as we went along. I think what really was interesting to see happens is the hospitals were struggling with how do we deal with COVID patients? How do we deal with non-COVID patients and keep them separated? But also, how do we deal with the financial loss when all elective surgery is shut down, when people stop going to the doctors, except this huge new sort of moving towards virtual care. So they're sort of trying to figure out these three things as we're going through. And I think it really impacted the hospital, like getting down to the bottom of the pyramid from an institutional point of view. They were just figuring out how to deal with sick patients, but at the same time, they were thinking about their bottom line. I do think, though, that what started happening as they got control over things here in the States is we started having a dialogue happening between the different hospitals. And here, hospitals are sort of in a competition with one another rather than complementary. But it was interesting to see this dialogue beginning to happen, which was really thinking about how to have a sort of networked, resilient sort of system approach, and start thinking about how we might address something like this in the future, quicker, faster, but actually working together. I think that's something that I saw on a more macro campus level type situation within the COVID crisis here.
That's fascinating. Paige, how about your experiences? I know you have a lot of background in residential long-term care, and that was a real issue, especially in Canada, with the chronic underfunding of residential long-term care and kind of the invisible way for governments to balance their budget that came back with a vengeance in this particular pandemic. Where do you see what happened there, and how could we do better?
I think one of the first things that became clear is the integration and interdependence of politics and public health. And we could see how a policy decision that affected the population could result in a very tangible, very visible kind of health outcome, and how we could change behaviors and change those outcomes. We also saw the amazing resilience of people providing care and how they absolutely stepped up to the plate. And it kind of made it clear that it almost doesn't matter what the space is. Care is going to really come from people, and they are the fundamental piece of this. When it gets into lessons learned in long-term care, what we found are a couple things. One is the newer facilities that are really designed around a private room with a private washroom for every resident had a little better opportunity to control the spread of infection from room to room. So we have situations in older facilities, for example, where we'll have 4 people sharing one tiny bathroom that you can't even get a person and an assistant in with a walker, sharing 3 other toothbrushes, 3 other bedpans. You can just imagine the chaos of trying to control the spread of an infection in that setting. But the other lesson there is it really doesn't matter if you can control it well or not. The idea is to keep the disease from even getting into the facility. So it became important to hermetically seal our facilities, to keep everything out, keep people out. And in long-term care, coming back to the pyramid, that's a really critical piece, because in long-term care, this is where people live. So that created a lot of tension because, well, no, we can't just abandon everything else and just deal with critical sick care. This is a place where people live, and we have to actually provide those elements of comfort. We have to let their care provider family members come in and participate. We have to let a clergy person come in and participate in their care or their life. And this introduced the concept of, like, how do we control and seal our boundaries? And then lastly, the social contract that we have with the people that are providing the hardest basic care, frontline workers, their unpredictable and uncertain employment situation where they might have to work in 3 facilities made it very hard to, control the introduction of disease, and also the, not having sick days. So I feel a little sick, but I've got to go to work. Well, that's how it gets into the facility. It's not their fault. It's our social agreement with these people.
Yeah, I think just building on that, your points are well taken. The initial reaction is keep everybody out, keep the residents safe. But what sort of mental impact, behavioral sort of health impact is there when you're going from weeks to months to a year of not, of only waving to people from outside, et cetera? One interesting thing, Benji, is that I think Canada is ahead of the United States, where the Emergency Conditions Committee just published a paper recommending in the States that all new residential care construction is single patient or single resident rooms. Right. And I think that's going to have a large impact here. There may be a fight against it from the business model. I think it's the way to go. Those patients obviously, or residents, fared much better. But I think that is where Canada is a step ahead, because my understanding is that you've already made that step for new construction. So.
One of the things that really struck me, my mother was in a long-term care facility, again, this was in California, locked down for a year in a single room or single apartment. But while everyone else could work with distance communication through computers, for a lot of older people, this is not an easy thing. They can't manage it, they can't push the buttons, they can't read it. And it seems to me that that's a kind of huge area, not only for like telehealth delivery for doctors, but actually fundamental communication for people who are basically trapped in these in the sort of healthcare web of your daily living space.
Yeah, it's a good point. I mean, it's the interface that's designed and used by the user, especially for the older user, is integrally important to the success of being able to use these systems. The new hospital we opened at NYU Langone, there's a tablet that the patient can actually operate everything in the patient room, from the automatic shades and slides to FaceTiming with family members at home, but all within that one tablet. But if you can't use a tablet, it's not much good. You're still relying on the nurse or someone else to actually be the intermediary for you.
Yeah, so some communications help. So next question, I'm wondering, what were some of the spatial design and architectural aspects of our existing healthcare facilities that really hindered the ability to provide response and quality patient care during COVID? And Benji's talked about how precarious our systems are, and we've started to refer to old stock versus new stock, and obviously it's different from long-term care to hospitals, but perhaps each of you could talk about some of your experiences, what you encountered.
Yeah. I think, Benji, when we're speaking to clients, we use words like adaptability, flexibility, designing for the long-term future, and things like that. I think we learned very quickly that our buildings are not flexible, that they aren't really all that quickly adaptable. Obviously we didn't have enough beds. We didn't have enough ICU beds, and it's not like you can quickly make an ICU bed. Emergency power, medical gases, things like that. So I think there was a struggle to figure out how to increase our capacity. That's something we're going to have to address in our future designs. We need to run and play out more of these what ifs. What if this happens again? How can you increase your bed capacity from 552 to 1,048 or something like that? So these are things we need to focus in on. I think the other thing that we really were lacking is in this mechanical sort of system point of view, which is providing negative pressure spaces. The negative pressure spaces really are not there so much for the patient. They're there to protect the caregiver. And when we fail to have enough negative pressure patient rooms and other things like that, we are putting our caregivers at risk. So I think there's some real base infrastructure that we need to be thinking about how we make it more robust in the future. and talk to our clients through those what ifs, but also talk them through the what if you don't do something like this? What are the implications if XYZ happened?
Yeah, I just building on those points, Brian. I would, our hospitals really faced the issue that those adaptable spaces, as you say, really couldn't withstand a long-term use in an adapted way. So, we might be able to deal with a hurricane situation or a mass casualty for a couple days. We know a good emergency department can set up a tent out in the front parking lot and do great care. But can we provide quality care for a sustained period of time? No. So what this tells us probably is that we center the hospital in the center of our system at our own peril, and we need to look at things much more as a broad system, person-centered, patient-centered kind of strategy. Generally our hospitals fared well. And we will see all kinds of new lessons learned be imported into our hospital design standards, increase the ventilation, which is going to decrease the efficiency of that ventilation, the environmental viability of those systems. It's going to increase cost. But, our hospitals perform pretty well. It's really the other buildings, you can't shut down a nursing home because people live there. Schools, how well is our ventilation suited to continuing classrooms? What about our work environments and our homes? What about really dense populations and, how disease spreads so very quickly? These are things we really have to be focused on, not just focused in and on hospitals and healthcare designs. I think we've got a lot of evolution that's come out of things like H1N1 and SARS in 2003, where we've learned a lot of lessons that we actually applied to space, and those spaces that were designed using those lessons learned from SARS certainly fared well under COVID.
Well, Canada did, I think, externalize a lot of the pressures on the hospital because of the population take-up and relying on the population to conform to public health directives. And in the US, that was certainly the case among wealthier populations that could afford to isolate, that did have cars where they could keep themselves separate. But where the US really found the challenges is with people living, poorer people, working class people, living many families to an apartment, having to take public transit, where they didn't really have a choice, and working in frontline jobs, all different kinds of frontline jobs, essential workers. And in Canada, similarly, it was the weak link in the chain was obviously the long-term care facilities, which is disastrous both in Quebec and in Nova Scotia.
If I was going to shout out for Nova Scotia, we had an incredible public and political framework that was very, our public health and our politics were very tied together in a very health-focused way. So we had a very strong decision-making process at maybe great political peril, like shutting down businesses and lockdowns and those kinds of things. But to your point, Christine, we saw the results of that very quickly. And even in those very controlled situations, we were still putting people who were in critical ICU situations on a ventilator, on a helicopter, and moving them to another hospital, even in Nova Scotia, just to control our limits on equipment. So we can see how if we respond, we can actually adapt our own behaviors to suit the system rather than demand that the system suit our behaviors.
So it's an interesting thing when you think about systemic design, a bit like Brian's comment about hospitals that would often consider themselves competitors working together to build in that resiliency, or being able to rely on populations to comply with population health directives. You can actually depressurize the system. And that's an important step in developing resiliency.
I mean, just quickly, there's fewer deaths if there's fewer people infected, and 2% of your population infected in Canada, 10% in the United States. A real factor here was not having strong scientific-based information coming out of the White House. And also, we can't underestimate a large population feeling there's a conspiracy theory out there that COVID doesn't exist. Education, things we're going to have to work on in the future to have greater trust in our government, and well, actually having an adult in the White House is a good start. So
I have one other question before we move on to the next section. To prepare for pandemics in the future, we've talked about a couple different strategies now. And Bryan, you've talked earlier about some of the strategies that can be done in new hospital design. But I'm wondering what might be able to be done within older facilities to be better prepared for future pandemics and crises. And is that more about the things we've just been talking about, or are there some fixes that could be done sort of straight out to help? Either Benji or Bryan.
Well, I'm happy to start. Renovations in healthcare facilities are very difficult because we have people in these facilities who are frail, sick, compromised, immunocompromised, and they can't really sustain change. Electrical shutdowns, water shutdowns, dust, debris, noise. And so often we can do like adding pieces on. It's hard to renovate in an operating facility. It's almost got to be cleared out. We've done entire renovations in surgical suites while surgeries happen. I mean, it's possible. You do the surgeries in the day, you do the renovations at night. It is possible, but it's extremely complex and expensive. I'd still come back to going forward, like what can be done even with the older facilities. I would still try to externalize a little bit, and I think Bryan's going to have a little bit different answer to this. We need to think about our other building stock and where we can make improvements. And also we need to be very evidence-based. We need to have robust research, blind studies, those kinds of things before we make just correlated design decisions, which is typically how we do things. We experience something and we're like, oh, let's respond with a design that addresses that. And going forward, I think we are going to feel the long-term impacts of COVID, past another decade, and we actually need to be start preparing for that next pandemic that's coming, whether that's mental health or undiagnosed situations because people didn't go to the hospital, as Bryan was mentioning.
The hospital usually isn't one building or two or three or four. It's many, and they're over decades or even centuries, really. So, when I'm asked a similar question, Christine, but in a different way, which is, well, what should we do here? What should we do in this building? What should we do in that one? This one being brand new in planning, this one existing. I try to speak with the client and ask them to take a step back and say, let's take a look at your entire inventory, let's say, of buildings, and think of it as a system or a network. And then if we start thinking about how that entire system, each building block within it, should respond in the next pandemic, then we can start making smart decisions about what we want to do with each one of those. Quite often, the older facilities, we do what we call downgrading them, putting lower acuity patients, outpatients, admin, and things like that in them, because to renovate, renovation is very expensive, but to renovate a building that has low floor-to-floor heights, that is going to be mechanically compromised in any case, is not money well spent often. So.
Okay, great. So in terms of, I have sort of another section I'd love to talk about, but I'm aware that we're running it. We should really turn it over to the Q&A. So we'll have these other questions as a sort of backup. So I'd really like to segue now and thank you for these initial kind of comments with your expertise and knowledge on this topic. But if it's possible now for us to move to some Q&A, and then I have a whole bunch of backup questions that I'd like to ask you as well. So we'll see what pops up on the screen. So our first question is from Colleen Brion, and she asks, how is design changed by the general age of the population? Is it forward thinking for the needs that we anticipate for the future regarding design, layout, and area size? So in other words, with an aging population, in terms of aging demographics, How should we be thinking about the design of healthcare facilities or long-term care facilities in this regard?
You want to take this one?
Well, absolutely. In Canada, demographics play a part in healthcare facility planning. And those demographics definitely age as a component of that, as well as things like the prevalence of certain kinds of disease. So this all goes into, our trends projections when we're planning how much space do we need, what kind of space do we need, and how we respond to what's going to happen, 5, 10, 15, 25 years into the future, and making sure we're ready for that when we make an investment. So certainly the way a government in Canada responds to need often has to do with, the actual demographics factually. There's also a response that tends to be a little political, because projects in Canada are sexy political things. And so it's possible to leverage a new hospital or a nursing home in a community for political expediency. And so that is also part of demographics, I think, about who votes and why do they vote.
Yeah, I'll give a tangible, I guess, example is that we are now seeing more frequently a geriatric zone or area within an emergency department, with greater considerations to noise reduction, ease of use of components, more comfortable chairs. I mean, geriatrics who arrive to the emergency department usually have a longer length of stay because they're many comorbidities, they're on many medications, there's often a dialogue inconsistency going on. They require more lab work, and lab work takes time. So we're starting to see specifically designed, more, I would call, elderly friendly or geriatric friendly components, similar to like how we actually have pediatric emergency departments, et cetera.
Great points. Okay. So another question. This is from Abrar Bazara. So the question here is, the adjustments that we've made in healthcare during the pandemic, are these going to hold for future changes, or are we going to see them just reverse back to what was the status quo before? And to what extent is this systematic? And can you think of any examples?
Yeah. So I'm not sure what happened everywhere in Canada. I know it was very interesting that we design buildings, and I'm on these guidelines. We design buildings, and they're reviewed by the Departments of Health. They tell you whether you comply or not. You get a license and a certificate of need, and it can take on months or years for these meeting all of the conditions. That went out the window. That went out the window with the pandemic. Essentially in New York State, they just said, just tell us what you're going to do. Just like send us a note and tell us what you're going to do, and we'll sort through it later. Do I think that's going to and you can deliver safe care, I guess, in some of these makeshift environments. Is it the safest care? Is it the right place? Is it appropriate setting? Probably not. There are regulations. The Emergency Conditions Committee in the United States has come out with a recommendation, a number of recommendations going forward. I personally do not see that we will see a relaxation in the minimum requirements for healthcare spaces, with, I think, one exception: the greater allowance of flexibility or shared multiple use space to say, hey, I'm designing as this, but I'm also designing as this and this and this, but I'm not going to comply with all of it because its primary use is this. So I think that's one thing we might see.
I will just add that, I love that question because there are two ways to answer it. One is, there's a lot of risk that we're going to go back to the old ways. And the other thing is like hope, because COVID was actually quite disruptive. You can see how the correlation between like a strong public health policy can change public health outcomes. And imagine if we leveraged, in our province here in Nova Scotia, what it means to have a health official in charge, really tied to the hip with the politics and making great decisions for a health outcome, and applying that to other things like lifestyle or other kinds of health predictors. So I think we're for sure like entering a new era, and COVID has accelerated this. I think we'll start to see patients deciding a little more about how their healthcare will be delivered, because they'll start to, increasingly have control over the data. We've seen integrated systems happen, like our vaccine rollout is an incredible, nearly seamless rollout system. And why would we ever go back to the old way of doing flu vaccines? So these little changes make a lot of difference. And I think we're going to start to look to other kinds of technology. We've seen telehealth. We're going to use AI. We're going to use other kinds of handheld diagnostic tools, monitoring tools, telehealth, big data, minimally invasive procedures. And everything is going to be part of another pandemic, which is probably a skilled human resources shortage, which is going to require us to, respond in the way we've responded to COVID. We know that the integration is possible. We know we have the ability to do things. All we kind of need is a little bit of will and maybe a bit of a cost benefit, and the system will kind of integrate itself, maybe because of innovation, but also maybe out of necessity.
One of the things I was struck by in this pandemic is the sense to which people felt like they were pulling together to defeat this challenge. And I think that's a really rare and unique opportunity to live through. And that sense of collective endeavor, I wonder how many other things we could learn from some of the challenges we're facing in terms of climate change, in terms of social justice and equity, in terms of our history with Indigenous communities. It seems like those strongly held, collectively felt, and directly experienced challenges that we face, when people pull together, it's quite amazing what can be done, not only in the design of facilities, but in how we interact with each other. And I think that relates to Sophia's question about silver linings, what potential may have been revealed through the pandemic in healthcare design and elsewhere.
Well, so just building on what you said, I think this collective sort of experience was also terribly humbling. I think it was very humbling for the entire nation and for our entire healthcare system. I think the silver lining for me is that we recognize that in many cases we did really great. The shifting to telemedicine, the setting up 2,000 beds in the Javits Center to create beds where we haven't had it before, the education, things like that. We also failed, and when I say failure, I mean when you understand a failure, you can then address it and make it better. So my silver lining is understanding where we did fail. We failed terribly, and I don't even know what the the impact nationally is going to be on healthcare workers and families who lost loved ones, who died alone. And that's an operational issue. There's no mechanical reason that a family member cannot go in with full PPE and be with a family member when they're passing away. We need to fix that. We need to figure that out. The caregiver should not stand in place of the family member holding up a phone as someone is wanting to say goodbye. So I think that's a silver lining. I think the other silver lining is that people are starting to understand that it's very important to address the frontline workers' needs, their environment. And I think we need to start thinking about spaces, not that are just functional, but they're also generous. We need to create generous spaces. And it doesn't mean it's a lot more money, doesn't mean it's a lot more this. It means thinking important, like that top part of that pyramid. How do you design in things where they don't go away when you get into that critical mode? Like, for example, we all need fire stairs, but if you put a stair in the right location, people use it to go between floors. If you put it along the perimeter, you have a wall of glass in it, you make it a little wider, it becomes an area of respite. It becomes a space to go to. And it's these kinds of things that we owe to our healthcare workers to start designing into our environments.
So I think that's a great comment, going back to this pyramid of care and your alternative model of building in resiliency. It's not just building in resiliency for emergency, obviously things like the pressure differential and things like that, and how you handle air and deal with sick building syndrome, etc. But it's actually putting in the essential qualitative pieces that are going to allow it to deliver what human beings need, which is, soul and spirit and mind and emotion, as well as anatomical body and, kind of core health. We are mind and body together, and to focus on the body without the mind, you have a real absence, a real lack in some fundamental understanding of what people are. And I think that really became very evident here. There's a number of questions about that people are asking about, online, about the kind of, feeling of isolation, and you've referred to that too, Bryan. And it seems like that's a kind of core lesson that needs to be addressed in the most any sort of design going forward.
Yeah. I think one thing that Benji and I do is we take what we hear from our clients and we take it to our other clients, right? So, when healthcare is very outcome oriented. So I think we all know that daylight is a good thing. We all know that lower noise levels, helps with sleep and things like that. But I think what our obligation as designers and architects is, we need to be educating the CFOs, the ones who are putting the money into these things, on the importance of these qualitative things, which are a little harder to describe, and they're harder to have a piece of paper and say, look right here, this is the percentage give back you're going to get. And I think some of it will come from making sure users, staff, family members, former patients are more involved when we're designing new spaces, because that's when you start to hear the qualitative, like you hear the personal stories and the emotional experience, and those are the things that I think we're lacking in a lot of our sort of design of all spaces, really.
There's also issues like post-occupancy evaluation, these kinds of studies done in housing. It seems like you could have post-pandemic evaluations of the actual concrete costs. So we're looking at mortality, but we're also looking at mental health issues, and we're looking at the inequities around inequities of care having to do with demographic differences. Do you think any of these issues might come in maybe ways that can be substantiated in the design of future healthcare facilities and long-term care facilities?
Certainly, in many institutions, COVID shone a light on inequity and racism, oppression, and systemic issues that have been long-standing. But somehow, under the stress and the strain, these things were able to come to the surface, and still are. I think these are going to have lasting effects, both positive and negative. The positive ones are going to be hopefully things that change to increase accessibility, to increase equity, better healthcare outcomes for everybody. But there will be some challenges too, where the system is really trying to recalibrate itself and assess priorities. And I think we all kind of see a lot of infrastructure spending, for example, right now to cover up things, patch things up that actually are long-standing issues, not COVID issues, but all of a sudden there's lots of infrastructure spending to fix it. Well, what happens if there's an effect after that that's a recession? How are we going to respond then? I think that's not necessarily a big scary thing. It's something we just need to be thinking strategically about. So the impacts of this are going to be very long-lasting, and I think we're going to start really questioning some of the big decisions that we make around particularly our investments in infrastructure. Is a hospital that we're building right now going to be really useful in 25 years, or are we going to have consumer-driven networks that solve patient needs right at home where they want them? And the hospital just becomes a little piece of the puzzle where a particular service or care element is provided, but everything else is consumer-based and patient-based, because someone's figured out how to disrupt it and make money off it, quite frankly.
Yeah.
It's true. Yeah.
Okay,
I mean,
sorry, Bryan, please.
no, I was just going to say, back to the silver lining, but exactly what Benji just said is, I've got a client who said, if you've seen one pandemic, you've only seen one pandemic. And but the good thing is we know we're getting through this one, right? So if we take the lessons learned of this one and we apply it, maybe we'll respond a little bit better in the next one, and then a little bit better in the next one, or the challenges are a little different, but hopefully over time, we are always moving towards a goal of maybe getting back to that, providing the right care at the right place and the right time to all people. And the right place means getting them there, but once they're in it, is it an appropriate setting, which goes back to that emotional, qualitative point of view. So.
Okay, I think we have time for one more question. There's a question here by John Ting, which also starts with a comment. And he says, welcome to the brave new world. Transformed ways to design policies, plans, and programs in healthcare. And one aspect of this, as you can see demonstrated by the speed that these vaccines have moved from bench to bed within 12 months instead of the 3 to 5 years in the past. I wonder if that level of pressure and obviously huge amounts of funding and support for it. So it definitely had a big carrot of money for the vaccine makers, but not all of them. Some of them were, provided globally, very low cost. I wonder how some of that strategy could be used for rethinking our healthcare system. Do you think there's any way that you can keep up the pressure on this to take advantage of some of the ideas that you've been bringing out here?
Geez, I love that question too, because so COVID hurt the economy. And so restoring the economy back to normal and also preventing an absolute breaking crisis in our global healthcare system, we fundamentally needed a vaccine. There wasn't any way around it. So that's where the economics came into play around healthcare. The investment was there. Return on investment could be made by applying research to bringing a vaccine to market. If cancer had the same impact globally, or we could measure it in the same way even, or it had this like absolutely impending doom around a crisis in our entire healthcare system, we'd have a vaccine for cancer right now. We'd have also solved HIV. We would have these technologies already. We see the evidence of it. And I don't think there's any way to believe otherwise. It's all about will and return on investment.
We see that historically with something like cholera, which created basically all of our water and sanitation systems in the 19th century, the threat of cholera.
Yep.
I was at a fundraising dinner, and one of the guest speakers was Christopher Reeves, who was in a wheelchair speaking, on a ventilator, et cetera. And he talked about, well, in his case, talking about, spinal cord injury, but also cancer and this and that. And he said, the only way that you'll have a cure is to throw money at it. You throw money at it. And if you throw enough money at it, you're more than likely going to come up with innovative solutions or cures, or at least to make lives more bearable or length of expectation when you have these diseases. So, it's right on the money that Benji was saying. It's policy, but if you put enough money into something, you are going to see significant advancements in that one area.
Okay, well, with that, I think that's a great spot for us to think about wrapping it up. So we're right at the nexus of what are the priorities that we have as a society, whether we're paying for it through government or whether we're paying for it through corporations, through companies, business, and the private sector. It all comes down to the same thing. Where are those priorities? So with that, I just wonder if you have any final thoughts by way of summary that you'd like to share with us before we close in a few minutes.
to you, Benji. Less about COVID, but this actually process of working towards having this dialogue, I think, was very interesting. And I think having, both graduates from, Dalhousie, but having different experiences on different scales and different countries has actually educated me a fair bit. And I think will only make me a better architect and designer and planner.
Yeah, I just say that the questions we ask, the things that we demand, the way we get the media interested shapes our world. And as designers, we can only go so far. If the will isn't there to do something that improves the system's not going to improve. And with that, I'd also say I would focus on the system, because we have so many examples right now in the last 18 months where we can absolutely knock it out of the park to make change.
Well, with that, thank you. We've reached the end of our time. I'd like to thank you both, Benji and Bryan, for sharing your expertise, for taking the time to participate in this. And I look forward to seeing where this conversation is going to go in the future. I'd like to also thank all of our guests. Great questions. I wish I could have just addressed them all or brought them all up for Bryan and Benji to talk about. And with that, good evening. Stay safe.
Thanks a lot.